Hello, web shadowers. Thank you all for attending our session this afternoon.
Today is the last session for our spring 2021 semester, and we have the pleasure of hosting Dr. Malkoch, who will be teaching us all about general surgery.
As always, please remember that the Google form will be posted in the chat box and in the description of this video at the end. And please stick around for an announcement about our April roundup that starts tonight.
Is it okay to start?
So with that being said, Dr. Malkoch, you may start. Yes, you may start whenever you're ready.
Okay, perfect. Hello, everyone. I hope you can hear me okay. My name is Aldin Malkoč. Today, I'll be teaching you about general surgery, and we'll talk about a case today that's on a burn patient that had over 90% total body surface area burns. So, let me get started. A couple things. I just want to introduce you to myself. So a little bit about me. I was originally born in Bosnia and Herzegovina. This is a small little country in Eastern Europe. If you were to imagine, if you know where Italy is, you could probably take a little boat ride from Italy to Croatia, which is right next to Bosnia, and it would be about a 10-hour boat ride. I moved to the United States in the early 2000s, and I moved here not knowing any English, kind of got thrown right into elementary school and had to figure things out. And this is sort of where I learned and developed my passion for math and sciences. I think that this was something that was really easy for me to understand and comprehend. English was just always very tough. And in high school was when I developed this passion further developed. And I ultimately decided I wanted to pursue a bachelor degree in something more science-based. And so I decided to apply for a biomedical engineering bachelor's. I attended Arizona State University. So if anybody's from Arizona, that's really awesome. There, I completed my biomedical engineering degree in 4 years. Afterwards, I went on to complete my master's in biomedical engineering. I knew I had a very strong passion for it, and biomedical engineering was something that allowed me to sort of develop this side of me where I can be sort of an inventor, kind of do things that and help people in ways that I felt, were on a grander scale. However, this was also at the time when I realized that I didn't think this was for me. I didn't want to be that person who was stuck in a lab and who was constantly just sort of working alone. I was always a very interactive person. I love to, talk to other people. And from there, I decided I wanted to go to medicine. I started doing my shadowing, and, I'm really glad that you guys are here today doing this live shadowing experience. Started shadowing different physicians, volunteering at different hospitals. And so I ended up attending St. George's University. I graduated at St. George's University recently, and now I'm a general surgery resident at a hospital in Southern California. I co-founded a organization during my time in medical school, which was called White Coat Tutors, and one called Barbell RX. White Coat Tutors to me was it's a USMLE preparation company where I feel like the people that I've co-founded it with, we are able to really help individuals who are studying for step 1, for step 2, these national board exams for medical students, and help them in ways that, that I feel like is sort of really deserves and requires them. For some reason I'm cutting out, sorry. But yes, so White Coat Tutors is a USMLE preparation company that helps medical students prepare for their step 1, step 2, and step 3 exams. A little bit more about me. Some of my hobbies include powerlifting. I've been an avid powerlifter for quite some time now. One thing I love to do whenever I have any free time is I love to go hiking with my French bulldog. I always have pictures of her. She's the white one right here with the black face. But yeah, so I'll move on. So let's talk about what is general surgery. I'm sure some of you might know this already, but surgery is derived from the Greek word handworking. Surgery is essentially involves the procedures that involve cutting a patient's tissues or closure of previous wounds. So this medical practice involves performing various procedures that are associated with generally the gastrointestinal tract. So this can include things like the liver, the bile ducts, the pancreas, the spleen, appendix, intestines. Question I have for everyone is, who can tell me what the most common surgical procedure is in the United States? Oh. Well, I think I'm not getting anything. So I'll just say that the most common surgical procedure, so somebody said appendicitis, appendectomy, so removal of the appendix, colonoscopies. Actually, it's something, kidney transplant. Okay, so the most common surgical procedure would be a cesarean section. So that would be the most common. I think that in the field of general surgery, some of the most common surgical procedures would be appendectomies and cholecystectomies, and so removal of the appendix or gallbladder. Okay, so I'll move on. So who needs a general surgeon? So there are generally 3 types of reasons you would need a general surgeon. What do you guys think? So someone might have said biopsy, heart valve transplants. So in broader terms, we'll talk about it, but in broader terms, there are generally 3 reasons you would need a general surgeon. And so these reasons might be elective reasons, urgent reasons, or emergencies. So what do you guys think are examples of elective procedures? Right, perfect. So cosmetic procedures, things that generally a patient is going to elect to do. And these can be also hernia repairs. They're generally things that aren't, they don't cause too much of a disturbance in someone's life. Urgent procedures are procedures that generally need to be handled within 72 hours. So what might be a case of an urgent procedure? Right. So urgent procedures could be things like appendicitis. They could be things like a cholecystitis. Generally, things that you can wait a bit before you perform the procedure, but you do need to perform the procedure relatively early. Emergencies could be things that are going to be more traumas. So that's going to be your typical gunshot wounds, that some penetrating injuries as well. So those will be procedures that need to go to the OR immediately. In general, I think that one thing that also might not be totally clear is that general surgeons are also trained as trauma surgeons. So a general surgeon is always a good trauma surgeon as well. So they're going to be able to handle any of those incoming random penetrating wounds that happen as well. So moving on. So a common question I think I've had is, how do you become a general surgeon? And so my question is, how would you become a general surgeon? So I'll kind of show you my history, and then we can talk about it a little bit. So my history is that I graduated high school in 2012, right? So after graduating high school, I started immediately that fall at a 4-year bachelor degree program. Once I did that, I had to sort of plan, if I was going to attend medical school or not. And when at that same time I needed to take the MCAT and apply for medical school. As most of you know, applying for medical school takes about a whole year. And so you want to plan accordingly with everything else, right? So it takes about 4 years to complete your bachelor's degree for most. And then during that time, you have to successfully, take the MCAT, do as well as you can on the MCAT. And once you've done that, you can then either match into a medical school, or you'll be accepted into medical school and then attend it for the next 4 years. However, for me, I completed my bachelor's, and then afterwards I completed my master's in 1 year. This gave me time to take my MCAT, but also I was able to continue something I was very passionate about. I was working on a lot of research projects. I was working on a lot of new projects that were getting patented. So this was something I was really passionate about, and I wanted to continue it into my master's. And then so from there, from 2017, I then went on to medical school, and that was 4 years. And so medical school is generally 4 years. It's 2 years of preclinical work, and then it's another 2 years of clinical work. So your first 2 years, you're gonna essentially learn everything you can and then take step one. And once you take step one, then you're gonna go on to do your basic clinical rotations. These are things like internal medicine, pediatrics, OB-GYN, general surgery. And then once you complete all your very basic rotations in a hospital, you're then gonna take step two. And that's before your 4th year. And then your 4th year is generally comprised of more elective rotations you want to take. And at the same time, it also allows you, that's when you apply for residency programs, you do your interviews, and you find out if you match or not. So once you do match, so for me, 2021, you then start a general surgery residency. In most cases, general surgery residency is going to be 5 years. There are programs out there at, places, I think one off the top of my head is Stanford in California. That is a 6-year program. It's 5 years of general surgery residency, and everybody does 1 year of research. So there are some programs out there where it could be 6 years of general surgery residency. My program is a 5-year program. So from 2021 to 2026, that's about 5 years. And then after that, if you do want to continue on, you can do a fellowship. If you don't, then you are at that point a accredited general surgeon, and you could practice on your own. So all this time until I start is about 9 years, plus an additional 5 years after that for residency. So 14 years in total. Let me move on. Okay, so what can you do after general surgery residency? I think this is another question that a lot of people ask me, and there's a whole array of things you can subspecialize in. And so a couple common things is breast surgery, cardiothoracic surgery, colorectal. One thing of interest to me currently is critical care medicine and trauma, which is generally a 2-year program now. And then in addition to that, it's an additional year if you want to do burn surgeries. So about 3 years total. Other things, minimally invasive, which is really common. That's how most of your gallbladders get removed, or your appendixes get removed. So we'll move on to the next slide. So before we start our case, I want to ask if anyone has any questions at this point. And I'd be happy to answer any questions about general surgery, about recommendations for research during your time in undergrad, or just anything in general. Cool. So the first question, how How do I think biomedical engineering has better prepared me to become a surgeon? So to give you a little bit of context about why I really enjoyed biomedical engineering, it has a lot to do with my upbringing. My dad was a mechanical engineer by trade. My mom worked a lot in the healthcare field. And a lot of my time spent at home, being a refugee from Bosnia, it was working on things with my dad, right? And so my favorite thing to do was work on old muscle cars. My first car was an old, sort of beat up Ford Mustang that I was able to kind of bring back to life with my dad, and that was really fun. I think in addition to that, that allows me to sort of think in spatially, and that was something very unique that I took into my bachelor's degree. My mom, who talked a lot about surgical patients in general, more specifically surgical oncology patients, that was something that was also very unique. And so I think that for me, biomedical engineering gave me the opportunity to think more spatially. And so when I take that knowledge into general surgery, a lot of procedures are done minimally invasive, meaning that you're looking at the inside of a patient's belly. You're looking at it with a sort of a lens through a camera, and you're doing the procedures using tools, not necessarily feeling with your hands. And so you have to be very aware and in tune with your spatial awareness. And that was something that really I'm getting better at, but it was something that I sort of picked up very naturally. So I think having my background in biomedical engineering was very unique, and that sort of helped me pick up those little skills very more naturally. So somebody asked, what was my master's in? My master's was in biomedical engineering as well. Arizona State University has this program where they allow you to do a 4+1 year, where in 1 year you can finish your master's if you take some additional classes your senior year, and that's what I ended up doing. When do you take step 3? Okay, so step 2 is generally done between your 3rd and 4th year of medical school. Step 3 is done after you graduate. So for me, I'll be taking step 3 in about a month from now. But in most cases, individuals can take it in the first year or 2nd year of residency. So any resident can generally ends up taking it their 1st year, but you can take it up to your 2nd year of residency. So why did I choose St. George's University? Truthfully, St. George's University is an international medical school, and I always love the idea of giving back to the international community. I'm an internationally born, person myself. So I was born in Bosnia. I immigrated to the United States. And so I always felt like I wanted to have the opportunity to practice in different countries and have that experience. So I ended up going to St. George's University. And then if anyone has any specific questions about the international medical school route, I would be happy to answer any of those questions after our session. You can message me privately if you want, and then I'd be happy to answer any of your questions. So for general surgery, do you need to do a fellowship after your 5 years in residency? The answer to that is no. You do not need to do a fellowship after 5 years of residency. Once you complete your 5 years of residency, you do have 2 additional requirements. Those 2 additional requirements are that you take a written board and an oral board. These written and oral boards need to happen within the few months of graduating. But once you pass those 2 exams, you are a licensed and trained general surgeon. You can practice as a general surgeon anywhere in the United States at that point. So no additional training is needed on your part. However, if you do have an interest in anything further, then a lot of people do, tend to do fellowships. So someone asked, how did you know medical school was for you? I think that for me personally, medical school was something that originally, it wasn't my intentions to go to medical school. I'll be completely honest. I originally thought I wanted to be a biomedical engineer who worked in either research and development or someone who did a PhD. I spent a lot of my early time in my bachelor's program working in a lab. But this was sort of the time when I figured out that I always wanted to sort of help others in some capacity, whether that was a grander capacity where, you know, I would often daydream about that my medical devices might be able to help thousands of people. And, you know, this might have been kind of a little foolish of me at the beginning, but it was sort of what drove me and pushed me to work really hard. However, at the end of it, I realized that the interactions I had once I did some clinical research with patients and making a connection one-on-one with someone, that was what I really enjoyed. That was what really drove me and pushed me to do the research that I did. And then from there, I realized I think medicine would be the best route for me to fulfill that. And that's why I chose to do medicine. Cool. Okay, so no other questions. I'll move on and we'll start our case at the moment. So our case today is a car accident that resulted in over 90% total body surface area burns. And we'll talk a little bit about what total body surface area burns mean, what 90% means, and a couple other things. So, history of presenting illness. This was a 19-year-old male that presented to the trauma bay suffering more than 90% burns and inhalation injury after being trapped in a burning vehicle. The patient had been pushed against a light pole, and afterwards had a difficult time getting out of the vehicle, and as a result suffered these burns. The burns, if we were to describe them, they are described as leathery and consistent with full thickness, sparing only the plantar and dorsal aspects of the feet and bilateral areas of the hip. This means that the burns that the patient had suffered only spared the bottom of his feet and his buttocks. The patient, when he arrived to the emergency department trauma bay, had a GCS of 15, so it's a Glasgow Coma scale of 15 upon arrival. However, he was immediately intubated and started on advanced burn life support resuscitation. The patient additionally received bilateral upper extremity eschorotomies at bedside, and a volumetric diffusive ventilator addressed the inhalation injury. Cool. So before I continue, who can tell me what are the first things that we're going to do for a trauma patient when they come in to the trauma bay? And this could be, you know, any trauma patient. It doesn't just have to be a burn patient, but what are we going to do for a patient that's coming into your trauma bay who has either a penetrating injury, some sort of car accident with bleeding of some kind? What are we going to do for them? Okay, so some people said putting an IV, stabilize the patient, take their labs, okay? Make sure they're breathing and stabilize ASAP, check breathing, then stabilize. And then someone said ABCs. So in general, what we want to do is something called the ABCs of trauma. Let me see if I have, perfect. So we want to do something called the ABCs of trauma, right? And this is something that we would do for any patient that comes in. We're going to assess their airway. We're going to assess their breathing, their circulation. And then after those main three things are done, then we can get into the other ABC. So, you know, the disability, we might want to review the ABCs. Are there any drugs that the patient might have taken? Can we reverse them? What's their blood glucose like? You know, are they hypoglycemic? Can we give them sugar at the moment? And then we want to expose the patient as well, right? We want to make sure we check the patient everywhere. We don't want to miss anything. So we're going to completely expose the patient. We're going to look for anything on their back. We're going to look for any injuries elsewhere, right? So what do you think might be the best way to assess somebody's airway? And what does that actually mean? What do you guys think? So a lot of times patients come in, they might not say anything, right? The first thing I'm going to do, and someone said you could check their throat, right? So our goal is, can we look to see if the patient has a patent airway? Is anything obstructing their airway? And the first thing I would do is I would simply ask the patient if they know their name. So if you can tell me your name, then I can say that your airway is open and it's patent, right? And at the same time, if you know your name, you also might be neurologically okay. So your GCS then could be a lot higher, then higher to the point where it doesn't require intubation, right? So airway, I'll ask you your name. I want to check to see if it's patent. Breathing, how well are you breathing? So I might listen to your lungs. I want to see if your lungs are symmetrically rising and falling. And in circulation, I'm going to check for pulses. I'll check the pulse ox. We want to see if your extremities are getting good perfusion. So what do you guys think might be some, and our patient in the beginning had 90% total body surface area burns. So why was that patient intubated? They said he had a GCS of 15, a Glasgow Coma scale of 15. He was able to answer and he knew his name. And we still intubated. Why do you think that might be? So somebody said potential for their body to shut down due to the burns. That's really good. Airway protection. So generally it's going to be for airway protection. So we'll talk a little bit about why we want to intubate somebody that suffers burns, that's been in a very large burn accident. Someone also mentioned that their lungs might be damaged, which is completely true. So we generally think of burns causing injuries to the outside of our body. However, at the same time, all the smoke that the individual is going to inhale is also going to cause injury to the inside of their lungs. And so once those lungs get injured, initially they might be okay. But however, over time, their swelling could set in, edema could set in, and that's going to then compress on their trachea. And now we can then cause respiratory failure. We might have to have a difficult time intubating later down the road. So initially, large burns get intubated very early on. So let's move on to the next one. So our first thing, inhalation injury, right? So we can kind of see this image right here in the very top. This is somebody who's had no injury at all. However, someone who might be in 90%, who might suffer 90% total body surface area burns, they then might have burns that are very severe, such as in the grade 3, the severe injury, all that black soot, and that's going to be very bad for the patient. And in addition to that, all of that damage, once the edema sets in, then it's going to be very difficult for them to breathe. So we want to protect their airway early on and intubate them. Some reasons why we might want to do that is if patients suffer very deep face burns that are over 40%, that are full thickness, right? And we'll talk about what that is. Generally, large burns are going to result in edema, and that edema then edema would be a result of the fluid resuscitation that we're going to give the patient, and then that is going to cause their airway to be compromised. Or if they have a carboxyhemoglobin greater than 10%, or if we might suspect a cyanide poisoning, right? All these things that can happen from large burns or just burning material. So we intubated our patient. We're now going on to, we've addressed their airway. We have airway protection protocol in place. Their breathing is now fine. We've assessed their breathing by listening to their lungs after they're intubated. Their lungs are rising and falling as they should be. Their saturation is well. However, we notice that we can't feel any pulses in the patient. Why might that be? Okay, so someone said that the patient might have some form of skin swelling, maybe problems with their heart. Maybe their heart or their vascular system is shutting down. Their heart's not able to pump as well, so they're not able to get blood flow to their extremities, okay? Their skin is too thick, okay? Maybe low blood pressure. So low blood pressure generally is going to signify that the patient might have some form of shock or edema. So generally the cause is going to be from edema. So patients like this are going to require, burn patients in general are going to require lots of fluids. So the reason why is that your skin is a natural barrier for fluid to not seep out of your body, right? So if you lose your barrier, then fluid is going to leave your body. So we need to give you fluids generally just because you're going to also be, you're going to be losing a lot. And then in this case, the patient also, due to the fact that they have circumferential burns. So what a circumferential burn means that it's a burn that does a full 360 radius around the skin. And so as a result, it's going to swell. And if it swells in a circumferential way, then that's going to compress on any arteries, which is going to prevent blood flow. And it's going to compress on any veins as well, which is going to prevent return of volume back to the heart. So we need to do escharotomies. And these escharotomies are going to then open up the skin in such a way that we can then have normal perfusion to the rest of our extremities. So this is an example of our patient who required extensive escharotomies across his entire body, including his chest. The reason why that happens around the chest is that the patient might have a very difficult time being supported on the ventilator just because of all the fluid that's then compressing on his lungs and his heart, and more importantly on his inferior vena cava and superior vena cava, the two major veins that bring blood back to the heart, and it's causing him to be in a form of shock and where he has low blood pressure. So this patient required escharotomies. That allows him to have lymph perfusion. It allows us to achieve adequate mechanical ventilation, and we can avoid something called abdominal compartment syndrome, where we don't have excessive fluid retention in the abdomen as a result of the necessary fluid resuscitation that the patient will require. So you can see in this image sort of the location and area where you would need to do the escharotomies. Cool. So once we've checked our patient's airway, it's patent, we've intubated the patient, his breathing is okay, we've assessed that by checking his respiratory, by checking his lungs with a stethoscope, right? We've checked his circulation, so we now can feel pulses again once we've completed our espirotomies. Then we can continue our ABCs of trauma. We might want to then calculate something called the total body surface area, or the total burn surface area, right? And so what we want to do by doing this is we want to check to see exactly what is the total burn surface area. And as a result from this, we can then determine how much fluid resuscitation we need to initially start the patient on or give to the patient. So in most cases, you can see on the image on the left, sort of an example of a patient who's had massive burns. And on the right, you can see an image that shows how we might add up our percentages. So for an adult, the front of the head is going to comprise 9%. The arms are 9%. The front torso, the anterior portion, is going to be 18% total. The back is 18%, and your legs are 18 and 18. On a child, it'll be a little bit different, but essentially just because of babies having larger heads, their heads are going to comprise 18% versus 9% in an adult. And your hands themselves are going to be 1%. So we'll add up all the total burn surface area for this patient, and then we can start them on adequate fluid resuscitation, right? So for our patient who came in, who was trapped in his vehicle, only had very small areas that weren't burned. He had over 90% total body surface area burns. So how are these depths of burns categorized? And then I have some examples of what might be the temperature where you might suffer some burns at. So on the left side, we have an example of what the different layers in the skin, from the epidermis to the dermis to the fat to the muscle. Generally, your first-degree burns are going to be very superficial. This is sort of similar to when you go sunbathing outside and you forget to put sunscreen on. Then we have examples of second degree, but second degree is broken down into partial thickness and deep partial thickness. And third degree finally is full thickness. When a patient comes in and they tell you, and this is a general rule of thumb, if they tell you they have a burn, then they have no pain at that site at all, you can assume that it's probably down to the muscle, that they've burned off even their nerve ending, so they don't even feel pain. So let me just keep going. Okay, perfect. So a couple different examples again of different areas that will have different burns. So the superficial burns, like we said, is similar to sunburns. They're just localized in one area. They might be painful. The one thing you want to look for is that there's no blistering yet. They're just painful. Your superficial partial thickness and your deep partial thickness burns, these burns both will have blisters. So on this picture, you can kind of see that the burns have blisters, and the skin is, and the blisters that are popping, and they're fluid filled, and there's the skin sloughing off, right? These are also painful. However, once we get to deep partial, it's painless to pressure only. And once we go to full thickness, you then have burns that are white, they're no longer red, and they're painless. You can only feel deep pressure. That's generally a patient that's burned even their small little nerve endings off. At this point, I just want to ask, does anyone have any questions about the depth of burns at all? So someone asked, are there any burn cases that require skin grafts? Definitely. So we'll talk about this patient. We'll talk about the requirement for skin grafts. So someone also asked, how do you practice aseptic techniques or sterilizations for those open incisions so that the patient doesn't get an infection? Good question. So in the trauma bay, you're gonna have material and you're gonna have sterile gowns that you can dress. And at that point, we will clean the patient as best as we can using different aseptic techniques so that we can then have a clean working site when we make our incisions. However, the incisions then are also dressed with a material that we call polysporin in zero form. This is also sort of antibacterial as well. And this is just preliminary until we can get the patient in a couple of days to the OR once they're stable and we can start the skin grafting procedure. So someone asked, do you work closely with dermatologists and or plastic surgeons with burn patients? So this kind of can vary from institution to institution. However, dermatologists generally don't work on large scale burns like this. This falls under the category of the burn surgeons, or it can sometimes fall under the category of the trauma surgeons, of the critical care ICU surgeons. So in these cases, at our institution, anything that is from the neck down is going to fall under the care of the burn surgeons, which at our institutions also the surgical intensivists, so the surgical critical care surgeons. Anything that involves the face or sometimes very delicately the hands, that will be handled by the plastic surgeons. So someone else asked, with full thickness burns and the burning of the nerve endings, will recovery be less painful for this kind of patient? And this can vary. We have seen patients that generally don't complain of too much pain. However, most patients will still have pain as these nerve endings start to grow back. And as the nerve endings grow back, they're no longer very localized and specialized. And so in most cases, patients actually complain of more pain as the nerve endings grow back and they become more specific and more local and very specific to the area that they're growing back into. In more cases, you kind of think of it as a web that's growing back, and then over time, this web gets very specific to one point. But in the very beginning, it's just a web. So they feel a lot more pain in the very beginning. They'll feel sort of a burning pain more commonly. Cool. So we'll kind of continue. We can talk about some of the surgical procedures that happen with this patient. So we'll talk about the technical procedures right now. Perfect. Okay. So in burn wounds are generally excised in most cases. We want to excise any burn wounds that are generally of second degree or greater. And we don't take patients to the OR until they have at least stabilized. So at that point, this patient was first taken to the surgical ICU. He was given enormous amounts of fluids, sometimes upwards. In this case, a 90% burn patient might be given upwards of 40 liters of fluids in 24 hours to maintain their blood pressure and all the fluid that they're losing and that's seeping out. But once the patient is stable, they aren't requiring any increasing ventilatory support. Their vitals are stable. We can then take them to the OR. And at the OR, we want to do tangential excisions, right? So this technique was first discovered in the 1970s, and it requires the shaving of deep dermal partial thickness burns. And you can use different sorts of techniques for this. In most cases, it's a knife or a dermatome, and you're going to remove the area of the wound bed that's inflicted until you have nice bleeding. And sort of that's when you know, when you have nice little capillaries that are bleeding, you know that you've reached an area of healthy tissue. That point, then you're going to look for tissue that is not burned on the patient, which then you can remove and excise, and then you can then place on the area that you've now debrided. In our case, and so this first example shows you a patient with third-degree burns, and they're removing it and they're shaving off that dead skin that's on the top. Once that dead skin's removed, we can kind of see in the picture on the right side, once we remove all the third tissue, all the tissue that's dead, we can then replace it with good, healthy tissue. And this is our skin graft that we're doing. However, in our case, this patient did not have any healthy tissue. So in these cases, you can use things like cadaveric tissue. So individuals that donate their body, they might have, we will also use the tissue from it, the skin graft. So we'll use cadaveric skin. And at that point, this is just a temporary measure just to control the patient's sort of fluid loss, and at the same time, start promoting some healing. We opted to use a combination of the cadaveric tissue and also a new technology that was invented in Australia called Zorb. Zorb is this biodegradable skin graft, or not skin graft, but biodegradable graft that can fully encompass and incorporate into tissue that has been burned. And once you removed any of the dead tissue, and that then you can graft right on top of it. So I'll kind of show you some images that I think are really cool. So and this is just partially of my interest, but I really enjoy research, and this is sort of the new developing research in the burn, in burn. So the Zorb, you can place it on someone's dead tissue, and essentially over the next 2 to 3 weeks, once it incorporates, it's then going to be ready for grafting. So we use the combination of the cadaveric to start growing some of the patient's own tissue where the burns weren't too bad. And in the areas that had full thickness, or even sometimes down to like fat, those areas we placed the Zorb on. In this case, once we did that as well, once we also combined it with an additional product called RECELL, which is sort of a sprayable skin graft. You take a small piece of tissue from the patient, and you can create a large amount of sprayable skin graft that then the patient's own skin will be able to grow back. So let me go back real quick. And for this patient in particular, these procedures were repeated. And essentially, burn procedures, the hardest part of it is everything that goes into the preoperative management and the postoperative management. The procedures themselves, like these, are quite intricate. However, they aren't going to be like your oncological procedures where we're removing a lot of things and we're spending a lot of time in the OR. In this case, this patient was at the hospital for about, I would say, 4 to 6 months. And we worked on small areas at a time. And we were simply repeating the same thing over and over and trying to get the best results for this patient. Does anyone have any questions at this time? So someone asked, how long would this patient take to fully recover? So this could be a while. I've actually, from when I started working with these patients, when they came into the hospital originally, they're still in rehab. The interesting thing at this point is that individuals who had 90% total body surface area burns about 10 years ago had only a 30% chance of survival. At this point, the chance of survival is about 50%. So in our case, we had 2 individuals that were trapped in a car, and both had similar burns and similar extent of burns. And both individuals required a similar approach. Both individuals also survived due to these new advancements in burn surgery. And however, the easiest part, I would say, is the part where we are sort of doing the procedures until we can get the patient to the point where we have covered all of their body with appropriate skin coverage. They've finished all their procedures, which usually takes about 4 to 6 months for about this level of this degree of burns. And once the patient has then been discharged, it's going to take years of physical therapy and additional work for them to heal and get back into the shape that they were. Someone asked, do you have to cross-match the patient and the cadaveric graft? So in general, no, you don't have to cross-match the patient and the cadaveric graft. The reason for this is you're gonna place the cadaveric tissue down for about 14 days maximum. At that point, the patient's gonna go back to the OR, and once they're in the OR, we're going to remove the cadaveric tissue or the cadaveric skin graft, and then we'll clean it up, that area, and we'll start working with it. So you won't need to match the patient and the cadaveric graft. So someone asked, how new is the sprayable skin graft and what are the risks? So how new is the sprayable skin graft? So the sprayable skin graft is a relatively new technology that's sort of coming to light in the burn world. I would say it's about 5 to 10 years of usage, maybe closer to 5. And some of the risks of it are generally going to be that it's not what surgeons are used to. And so at that point, the results are you have to be very careful about how you perform the procedure. And if you deviate from what has been approved by the FDA, I think that's when you can start having variable results. In most cases, we had really great results with it. And so we were really happy with using it. Someone asked, do you know how anesthesia is applied when full thickness burns occur? In general, the anesthesia portion should not change if you're dealing with a burn patient or if you're dealing with a normal patient. Most patients are going to get the same type of anesthesia when they go to the OR if they need to be put to sleep for the procedure. Right. So someone said, this is a great question. How do you give fluids to patients with large percent burns? It might be difficult to give the patient an IV, and that's very true. One of the difficulties we had with one of our patients was that when on arrival to the hospital, it was very difficult for the paramedics to place an IV. So in that case, what we have to resort to is placing central lines. So these are going to be some of the larger veins in the body. You have one in the femoral region, you have one in the carotid region, and you have one that's called a subclavian. So these are larger veins where we can place a much larger and more safe and more stable IV for the patient. And at that point, then we can give them, and it'll have multiple different multiple different openings into it. And so we can give fluids, we can give blood, we can give different things to the patient. Very cool. So I'm very passionate about research in general. And I think that's something that stemmed for me when I was in my undergrad. And I absolutely always loved to do research, and it kind of gave me the motivating factor for me to continue in medicine. It was sort of what drove me to spend those late nights in the lab. And I know a lot of you might, have to do the same thing. And so getting the chance to do research in your residency, I think, is really amazing. So once you do start medical school, I encourage everyone to do some form of research if you're interested. And then you never know what can come of it. So if you guys don't have any other questions, I just wanted to say one thing that's really important to me is that, you want to work hard. However, really important is to take breaks. I love to walk with my French bulldog. We go on hikes all the time. So taking breaks is really important. And the journey to becoming a doctor is really, really long. In most cases, if you are interested in becoming a general surgeon, it's generally even longer. Internal medicine hospitalist is 3 years of residency. General surgery is 5 years. Fellowships included in that. So it's a long journey. So I want everybody who's, at whatever point you are in your journey to enjoy it, have fun. And ultimately, I think you'll come to the ending. So it'll be really great. So I have my email address here at the bottom. If anybody has any questions about my journey through medicine, about attending a international medical school, general surgery in general. I would be happy to answer any questions right now, or if you want to, you can email me privately at this email.
Thank you so much, Dr. Malkoch. I sent in some questions in the chat.
Oh, perfect. So let me get through to some of them. Is silicone ever used in recovery treatments? I knew a Bulgarian plastic surgeon who swore by it. I don't know anything about silicone use in recovery. I'll have to look that one up. It's not something that we consider standard of practice, so I'm not too sure about that. So someone asked about tilapia fish skin. That is actually a really cool, innovative technology. You can definitely use tilapia fish skin. I've seen some places. I think that UC Davis does do that, and that's something that we might be incorporating in our institution as well. It makes a great xenograft for patients in the early, instead of using cadaveric skin grafts. So how do you address the psychological effects of severe burns have on a patient? What help is provided for individuals who sort of seep into a more depressive state after having such dramatic changes into their appearances? Yeah, so this is something that's really, really difficult. Like I said, the easiest part of what happens to the patient is what we do initially. Is those first 4 to 6 months when they're in the hospital and they're requiring multiple surgeries. The hardest parts that the patients are going to have to go through is going to be everything after that. And so while they are in the hospital, we definitely do see patients who end up having nightmares, end up having nightmares about the surgery, nightmares about the burn, nightmares about what happened, nightmares about the event. And we definitely do have psychiatrists who come see our patients when they need to. There's medications out there that are just for things like nightmares that we can try to give the patient and see if it helps. But patients do see social work. They'll see case managers. So they'll work with individuals who are specialists in their field to help them overcome this. Ultimately, after the patient also leaves the hospital, they'll continue to see social work. They'll continue to see their psychiatrist. And at that point, our hope is that we can then get the patient feeling better and overcoming the psychological effects. So what are some of your most common surgeries? I would probably say some of the most common surgeries outside. So I will be a resident at a very big and large trauma hospital. And so a lot of the surgeries we'll do are trauma patients. So patients that have either penetrating injuries, motor vehicle accidents, gunshot wounds, things of that nature. But then at the same time, the very sort of bread and butter of general surgery, your classical hernia cases, your cholecystectomies, your appendectomies. So those are going to be some of the more common things, the cholecystectomies, the appendectomies, even sometimes things like amputations. So we'll handle any amputations from patients who might have either for generally diabetic reasons or even like foot or toe amputations as well. How does treatment change for those burn victims that have had plastic surgeries like fillers, implants, etc.? So I would probably say that I haven't yet had the chance to experience that, but it generally would not probably change at all. If in any reason or any case, the implant that the patient has received, the fillers or whatever, is causing some sort of issue that we need to address, we can then obviously consult our plastic surgeons and see what they think. And if they think that we should remove it or leave it, or it won't be an issue at all. So in most cases, we will consult them.
Thank you so much, Dr. Malkoch, for presenting to our web shadowers and for answering all of our questions and for making the session super interactive. Thank you.
Yeah, thank you, everyone. It was a pleasure. And again, like I said, if anyone has any questions, please feel free to email me. I'll be happy to answer it.
Everyone, make sure you check out his socials. His Instagram is Aldin_Malkoch_MD.
Again, thank you so much, Dr. Malkoch, and thank you to everyone who came for our very last session for this semester. Please remember that the April Roundup will be tonight at 11:59 p.m. EST, and it will end this Sunday at the same time, 11:59 p.m. EST, and it will be your last chance to earn our Soldier Spring certificate. The Google form has now been posted in the YouTube live chat box, and it will also be in the description of this video at the end. And our summer sessions will begin in June, so please stay tuned for that. Again, thank you so much, Dr. Malkoch. It was an honor to learn from you. And thank you to everyone who came.